Welcome back to part two. I apologize for the gaps in technology here. Moving on with assessment for the female, we also need to provide education about the diagnostics that women should have so that they are aware of their annual screenings. And then things that we also would provide education on are things like birth control. It's really important that nurses know how to educate their female clientele on how to use to select an appropriate birth control, one that's not introducing the woman to harm, but also being used properly. And then the physical exam, after we've done all this other assessment, would include obviously knowing how to properly position a woman, with lithotomy being the position of choice for a female exam, a gynecological exam. Knowing how to inspect the perineum and the area around the perineum. The use of a speculum, and the use of a speculum is basically to allow us to have better visualization of the vaginal canal and the structures beyond, like the cervix. So your textbook goes into great detail about each component of the vaginal exam, but being aware of why a speculum is used, it also allows us to gather a good, clean pap smear without contamination. So let's move on to diagnostic evaluation of the female, and this is just a nice list that you'll see in your textbook as well. And you can see there that you do need to be familiar with the formal word for a pap smear test. Sometimes I've seen those in test questions in item in banks. But being familiar with what each test is and what it's looking for. So the pap is all about assessing the cervix, and that's really it. It's just the cervix. We're taking a sample, if you will, of sloughed cells from the cervix and sending them for histological, pathological review and looking for abnormal cells or anything that looks precancerous or cancerous. A colposcopy, or sometimes referred to as a cervical biopsy, is an approach where we are sampling, inspecting and sampling cervix tissue from the cervix, but it actually is endocervical, so we're actually moving into. So a pap is on the surface of the cervix, whereas a colposcopy is actually invasive. It moves into the space or into the actual cervix. Cryotherapy and laser therapy are the therapies that are offered for precancerous or non-involved cervical cancers, where they actually freeze the cervix, or laser, high-intensity lasers will burn the involved tissue away from the cervix. Cone biopsy or a LEEP procedure is a little bit more involved than cryotherapy. It involves laser beams again. These are all still done in the ambulatory setting, so right in an office this can happen. A D&C or a D&E is dilatation and curettage, or evacuation. So where the cervix is breached, it's dilated, and the insides of the uterus can be actually scraped, or things can be removed from the uterus. Typically these are done in either a procedure setting or a day ambulatory setting. An endometrial biopsy is the procedure that's used to go basically a piece of tissue is removed from the endometrial lining of the uterus. It's done usually under some sort of a scope or like a laparoscopic exam, which leads us down to the pelvic laparoscopy or hysteroscopy. Both of those refer to the insertion of a scope into the pelvis or the uterus to examine or perhaps take a biopsy. And then finally is the HSG, which is the hysterosalpingography. Say that fast 10 times. And this here is examination that moves beyond the uterus, and actually we're looking more at the tubes. It's really used to examine the fallopian tubes. It can be quite painful. Women can have a tremendous amount of cramping with that procedure. So some of the processes and perhaps alterations of these processes that we'll discuss today are these four topics: menstruation, the normal process, and the disorders that can occur. We'll look at contraception, ways in which we can prevent pregnancy. We will look at infertility and some of the treatments and our role as nurses in managing infertility. And then finally, menopause and different things, ways that we can help women manage menopause. So let's start with menstruation and disorders. For menstruation and disorders, I've listed here the same disorders that your textbook outlines in your reading. The only thing that I don't have listed here is the occurrence of Mittelschmerz, which is a German term, and it refers to ovulatory pain. Occasionally, I've seen questions about Mittelschmerz, and basically that it's just validated that yes, some women actually do have ovulatory pain. They can feel themselves ovulating. It's painful. It's typically radiating into the lower, heading towards the groin almost. Women will describe that as. But you can see here that we're going to cover premenstrual syndrome, which is the disorder that's characterized by women feeling achy, crampy, pain, sometimes radiating down through the back and the leg. They'll sometimes say that they have nausea and vomiting, and oftentimes we'll even talk about some mood changes. So maybe some depression, bouts of crying, and irritability can also accompany this. Although it doesn't have to. Some women won't feel those mood changes, but they'll feel those physical changes of premenstrual syndrome. Premenstrual syndrome is what's happening in the 5 to 7 days prior to the onset of menses. Don't confuse that with dysmenorrhea, which is periods that are difficult. So these would be women who have painful periods. They get their menses, they have lots of abdominal cramping during their menses, they're not able to maybe meet their own ADLs. Amenorrhea is absence of menses. Some of the things that can contribute to that could be stress, extreme weight loss, extreme activity. We sometimes see this in young women who are intensely training for different sports that they might participate in. Menorrhagia is excessive bleeding, so more than normal. And metorrhagia is bleeding in between, or abnormal bleeding between menses. So those are some of the different disorders that we might see when it comes to the menstrual cycle. Moving into contraception, some of the things that we have to consider when we're working with our female population is their need for contraception. And every woman's need is unique depending on her age, her previous health status, if she has underlying disease, if she's has multiple sexual partners, if she's had a history like PID, pelvic inflammatory disease, culture, her belief system, and plans for the future. Does she want to have more children, or any children, or never have children, especially with sterilization? You can see where that would be a concern. I mean, sterilization will not be an option if a woman has not ruled out having more children. Frequency of intercourse can come into play, spontaneity, does the woman know how to use it? So one of the things I do want to draw attention to, and this is important, women's health status oftentimes will drive what the contraceptive options are for her. And some of the things that we have to consider are any woman who has a history of thromboembolic disease, so clotting disorders or clotting factors. We have to use great caution when we start using hormones, because lectures that the increased presence of hormones, especially sometimes the progesterone and estrogen, can alter how the woman's coagulating, and it increases her risk of developing further clots. The other underlying diseases that we look at are obesity, diabetes, anything that has an effect on the vasculature, the vessels of the body. Things like joint disease, rheumatoid arthritis, those kinds of diseases, those typically won't be red flags or indicators that we can't use hormonal-based contraceptives, but it's those risks that put a woman in particular at vascular changes, so that DVT, the formation of clots, which could lead to a PE, right? So smokers are on that list. Women who smoke, we know over time, have vascular changes. Therefore, the birth control pill, it is not ideal to use that with a smoker. We would ask the woman to do a smoking cessation program before we use hormone-based contraception. So this graph just sort of outlines some of the methods, and your textbook does a nice job as well, but it's just a nice quick glance. The method, some of the considerations in the education. So, rhythm, again, this is all about knowledge. If a woman wants to use rhythm, um, it does have a low reliability with this, and she has to be very aware of her fertility periods and how to manage that. She also has to have a regular cycle. Just to be really good at taking that basal body temperature every morning before she rises from her bed, recording that on a log so that she can begin to track the trend with the elevated temperature, which indicates that she's fertile. And she would refrain from sexual intercourse just to sort of track that month to month. And she would actually want to stop having intercourse 5 to 7 days before the rise in temperature. When the temperature begins to rise, she's ovulating, but we know sperm can live up to 72 hours. So if she's just stopping on the day she sees the rise and she's engaging in intercourse the day before, it's not a perfect window. So we have to, review this with the woman who elects rhythm. Oral contraceptives, we've already talked about some of those risk factors. There are side effects, and that is usually breast tenderness, some weight gain, and some nausea and vomiting. And another big issue is compliance. They have to take this pill every single day. We also note there's some drug interactions, in particular with antibiotics, phenytoin for seizures, so folks who are on seizure disorder meds sometimes, and rifampin, which is what we see with TB. Those medications can decrease the efficacy of oral contraceptives. Then we have the patch, which is typically ethinyl estradiol that we'll see in that patch, and that is a hormone, so it's the same risks that apply to this woman as well. So we have to look at those health considerations. The patch, important teaching is that they leave it 3 weeks on, and then on the 4th week they take it off, and they should menstruate on that 4th week. They need to know that they have to do that to take it off. They shouldn't just leave it on, and so that they don't get a period. And they also need to know how to apply that, and that's soft tissue areas. So over the abdomen, the buttocks, the upper outer arms, but fleshy areas is where they should be applying that patch. Then we have the medroxyprogesterone injection, and again, health considerations like we've spoke about for hormonal. And this is an injection that's given once every 3 months. It's how long it lasts. And we give it typically during menses is when it's given, and they need to have backup coverage for about 7 days before we know she's covered. It takes, if a woman chooses to have injections for her contraception, we counsel that she should wait a year before she tries to get pregnant or has return of fertility. Abstinence, rarely reliable at all for some of the obvious reasons. And then emergency contraception, and this is high doses of basically the same things that you're finding in your oral birth controls, and then a second dose would be offered 12 hours later with slightly reduced dosing, but so extremely high dosing of oral birth control, and it has to happen within 72 hours of the suspected conception for fertilization. So that's super important for emergency. Like if it's later than 72 hours, it has very low reliability. Within the first 72 hours, high doses of oral birth control, a second dose 12 hours later, and we have to pay close attention to the nausea and vomiting that can occur with that high dose of hormones. I'm going to stop here and go into part 3, which will cover the barrier methods.